Greetings of peace, everyone. We're so excited to have you on the second day of the Second National Mosque-PCOR 2021. Today is Saturday, September 18th, 2021, and it is our second day of equipping Muslims with PCOR-based action-oriented research tools following the patient-centeredness in faith communities. A wonderful diversified panel today, and we're hoping that whatever we are presenting today will be bringing more insight and enlightenment to all communities participating and stakeholders who are interested in community wellness. With that, we start with good intent and a supplication for wisdom. Allah, we ask you for word of confidence, word of justice. We ask you to grant us genuine and sincere intention to make this world a better place. We ask you to come all together to work in for the humanity benefit and for bringing in wisdom into the sciences that we are practicing and bringing us all together, inshallah. Walhamdulillahi Rabbil Alameen, Allahumma ameen. We'll move along with our slides. We're so excited today that we're going to talk about the chronology of how things are have evolved and developed in a very short period of time since PCOR, which is patient-centered outcome research, has started. We have so many wonderful collaborators that have worked on making this happen. One close and dear to my heart is Worry-Free Community, which we have a wonderful representative, a very familiar face that will be speaking on that behalf. We have one dear and close to my heart, Initiative Islam Medicine professional institution. And I believe Pastoral PCOR Community Health is another wonderful collaborator who has given us insight on how to do this in the American society. Me in brief, I'm a family and a community medicine specialist. My name is Sundus Saad, and I focus on women's health and community empowerment. I've been working with faith-based communities since I was even before puberty, so I've been there over 20 years. Nobody should ask about age, as you may know. I am a participant of so many faith-based communities and NGOs, so I'm familiar with the challenges as well as the perks of working in volunteering forces. And I'm so excited to be the one moderating great assets today and contributors to making this reality and actualize PCOR leaders in faith-based communities, specifically Muslims, so mosque communities. Today we have, as I said, a wonderful diversified panel who have experience probably over decades. And we'll start with a wonderful chronological order on how things evolved to implementation, sharing lessons from implementation of PCOR toolkit that is specific to mosques. So we have wonderful sister Janice Tufte as the PCOR ambassador, who's been working for almost now over for a decade in trying to deliver the importance this in healthcare industry and exchange. And again, another familiar face that have been working fiercely advocating for communities that are underrepresented, Fatima Mirza, who is the Worry-Free Clinic director and presenting the hat of a PCORI investigator, a fierce one. And how that evolved into eMarch, bringing in all these people who are interested in Muslim communities' health into the eMarch 2017 to 2019, where a lot of researchers brought in their experience. So we have Dr. Sumaya Mushtaq and Dr. Michael Van Koolen, and how this kind of translated itself into an implementation and actualization into the IMPART project and participation since 2020 up to the present with Dr. Mahreen Box and Dr. Juwairiya Rasool. Moving to you, Janice, and looking forward to hearing from everybody else. If you don't mind, just make sure that maybe your cameras and microphones are held off while we are listening to our next speaker.
Thank you. I appreciate that introduction and dua. My name is Sister Janice Tufte. I'm from Seattle, Washington, and I've been a PCORI ambassador since 2014. I'd like to share a little bit of my story with you. Next slide, please. So I'll share my PCORI ambassador journey, and this is my website and my Twitter handle. And I use the hummingbird as a a recognition for the work that I do, because I believe we pollinate from one, opportunity to another opportunity, not only PCOR, but the work that we are involved in the greater communities. Next slide, please. So I have limited college, though my lived experience has helped to inform others. So basically, I've always been volunteer oriented, and similar to Dr. Sundus, I was involved with faith communities at a very young age. I embraced Islam in 2001 in February, and my experience and knowledge about community services in multiple counties was noticed very quickly in the Muslim community, and I was often called upon to assist in efforts when individuals were in need. We had a much smaller community in 2001 compared to now. We maybe had 5 mosques and masjids. And so basically in 2004, I had a very sudden loss of vision. I went from minus 425 to minus 1,000 ophthalmology numbers. And I was very fearful I'd go totally blind. And because I had mostly worked in volunteer efforts, I was a good saver, but I was always living in lower income. As an adult, I recognized I needed to move into low-income housing in a city because I did not have opportunities where I was living in the county before it was rural suburban. And so I moved into the city, and I got into low-income housing, a beautiful home, a mansion actually, where 7 women lived. And we all were just independently working and whatever, but had experienced some sort of, either trauma or mishap in our lives where we ended up living, in a lower income community. And so during this time, the Muslim community really rallied around me regarding my eyesight. And I was pretty quiet about being in a shelter. This is like lived experience, right? I knew that, the community would have offered me housing immediately, but I recognized that having the opportunity to be in some sort of permanent low-income housing would benefit me longer over time, not knowing what my site would entail. So basically, I decided, I was so grateful for the support of the community that I decided to create a new project every year, giving thanks to Allah and the community. And first one I created was the Muslim resource guides that are on the left. You can see them on my website, but basically they're for 3 counties. They offer mosques and community organizations, as well as the NGOs and government opportunities for individuals who might be seeking help for housing, healthcare, transportation, and other. So the next year I started what's called Warm for Winter project, where I was I started an awareness and direct service project around homelessness. So it was a 10-year mandate to end homelessness, and I came up with this number, 1,000 hats and scarves. And I created a project called Warm for Winter, 1,000 hats and scarves. I don't knit or crochet, but I saw people knitting and crocheting on the bus. And this is just how you notice where there's a gap somewhere, and you can create something beautiful with that gap, right? If you can see a solution. And to date, we've collected 50,000 handmade hats and scarves that have been delivered to individuals experiencing homelessness or in need. And we had 52 interfaith or ecumenical services around the Warm for Winter project, all around Thanksgiving, for 10 years, actually. And I still collect the hats and scarves, but I don't do the services have sort of run their course. The Muslims for Evidence-Based Healthcare was my attempt to really try to engage local Muslims in healthcare, just, where they could find evidence, because I saw there was a large gap there. I do run a Facebook page still. Next slide, please. So basically, I served on a medical center council with Group Health. It's Kaiser now, so I refer to it as Kaiser, for 7 years. And somebody from governance came and asked if I would be interested in reading a PCORI grant. I was like, what's a PCORI grant, right? And it was for the Research Institute, the Kaiser Research Institute. And I read the grant. It was a community clinic liaison grant for, social determinants of health, learning health systems. And I was onboarded, and we each, the other patient co-investigator and myself, we had our own office, our little cube. I had a view of the Space Needle, and it was just wonderful. We were paid a set amount each month, and we sat with the science teams, with the scientists, statisticians, anthropologists, clinicians, frontline staff, as well as the researchers. And we met a couple times a week in the beginning, and it slowed down to once a week or every 2 weeks towards the end of the project. It was the Learning to Integrate Neighborhoods with Clinical Care project. It was found to be so successful that when Kaiser purchased Group Health, they scaled it to all 28 clinics where they're serving individuals, and social workers are now able to work at their mental health licensure. And below is the first paper that I co-wrote with my patient co-investigator, and that was years ago, but it was really exciting to be published. Next slide, please. So basically, my involvement with PCORI led to many opportunities. I was a patient co-investigator and advisor. I'm a co-chair on multiple committees currently for PCORI projects. And I've also, the ambassador program has offered many opportunities to be able to be involved with measurement and guidelines. It's for myself anyway. They might offer, the Yammer social media offers opportunities to be involved if people would like to be involved, or they may ask behind the scenes. So I've been a stakeholder in multiple prioritization projects, PCORI priority setting agenda projects, and those help to inform measurement later, if you know, any of you know much about measurement. I was on a PCORnet project, the Portal project, where we developed toolkits, patient engagement toolkit that I think is very beneficial and you might want to look over and modify for yourselves. And the Translational Center through PCORI, we do plain language summaries and are paid a gift through a gift card for that. A presenter, I'm now presenting often, and my first really exciting presentation was asked to be presented at the National Academy of Medicine and, in Washington, D.C. And I was just honored to have done that. And I talked about the projects that I had initiated myself, Social Determinants of Health, and as PCORI ambassador. And I've been a panel member on the Clinical Guidelines Committee for the American College of Physicians and IDSA. I'm still on both of those. And a subject matter expert on multiple measurement technical expert panels. I still serve on 2 for National Quality Forum. One of them, we give recommendations directly to Health and Human Services. I am the only patient or public member on that panel, on those 2 panels, but on the guidelines panel, there's a lawyer that also serves with me as a public member. And we do have a public panel overall where they'll ask about outcomes and other, needed input areas. And so I've co-published 7 papers. I have a couple more right now that are in the works. And one of them is my first time as a first author. Most are, co-authored pretty deep into it. And I've been very involved with COVID. Right after COVID hit, first experience was here in Washington at Kirkland, a nursing home. I'm not sure if you heard of that. And so the outbreak. So we were very active right off the bat. The University of Washington, the Institute for Translational Health Services contacted me and asked if I wanted to serve on their prioritization and research project to bring the public voice. And we did fund 57 projects in COVID-19, and that was very exciting last year. MITRE, if you're aware of them, asked me to present. I presented on March 11th, the day the emergency was declared in 2020. And I spoke about vulnerable populations in COVID-19, and that's available on my website. And I now am internationally involved with COVID End. It's an international evidence effort where evidence practice centers from around the globe all come together and talk about issues. And I just was asked to be in a small group with WHO, COVID End, and Cochrane, where we're going to be providing input where recommendations will go forward to the WHO body. And for future emergencies, right? How do we prepare for that? So I always bring my PCOR voice into even evidence or whatever. And I'm on my first research poster was just accepted. I'll be presenting this at the end of the month. I'm really excited about it. And it's my first poster. And I will be, I'll talk a little bit more about the digital generation ecosystem that I'm involved with. Next slide. So these are just some hints how to be involved, right? I mean, this is what I have found that works. And I've heard this multiple times in different ways throughout the conference so far. But really, it's important to, know what the community needs. And I recommend registering for, informative opportunities, webinars, workshops, and others. Ask questions wherever you go. We're always continuous learners as Muslims. And, we encourage this and should encourage it in our youth and our elders alike. And we do believe in giving back. And I recommend to join organizations and other websites and listservs. As Sister Sundus had mentioned, I I became fairly well known in my projects because of being on multiple listservs, and I won a Community Connection Award from our Faith Action Network some years ago, and I'm still known as a connector in the research and evidence world. So as well as in the faith communities, I do some chaplaincy connection when they need some assistance. I developed a brand, Hasana Consulting for Good Deeds. Not many people know what that means. When they ask, I'll certainly share it with them. And I won a website, actually, so that was how I started my first website. And I have a very strong presence on LinkedIn, Twitter, and Facebook. And networking really is a way for us to share PCOR and other opportunities for individuals to be more involved with communities and to give back. And I believe that volunteering, one thing leads to another. And through myself applying for scholarships and conference, opportunities and work, I've really been able to advance my knowledge and be able to share it with others at those venues. And basically, always think about what research questions could happen. I initiated my first research idea this year, and it's with the University of Michigan Public Health, and a number of us PCORI ambassadors are all on that. We're waiting to see if it's to be funded now. Next slide, please. So this is where I'm at now, and this is so different than working my previous work for decades with individuals experiencing homelessness or living in poverty and community service, right? But I'm now involved with interoperability and digital transformation. So late in the year last year, I was asked to be a part of this ARC-ACTS project through a friend. And I attended a couple times, but I'm more of a systems thinker. So all those involvements I've been in now, I really understand are the basics of evidence, right? So evidence to guidance to action. And this is how we have effective clinical decision-making, shared decision-making, informed decision-making. But basically what they're doing, the website is there if you can see it, and I'll try to put it in the chat. But we're in the phase 1 proposal now, where we're hoping that ARC-ACTS will be funded for 3 years for moving forward. But we have developed the basis of FHIR, HL7 FHIR, if you know, fast healthcare interoperability resources, EBM on FHIR. We're developing each week new definitions, taxonomy and ontologies to be put into so evidence can now be interoperable and anybody can use it. And in this format that I'm working with, fever.net, it's voluntary, but everything we're developing turns into JSON automatically for those of you that know that language. And the idea is that we can have fair, findable, accessible, interoperable, reusable resources where you as clinicians and professionals could find information and articles that are pertinent to the work you're doing, right? Systematic reviews, guidelines, measurements, and where patients could also be involved in these processes as well as find out for themselves what they might like to know about their condition or disease. Next slide, please. So this is just some pictures of my involvement. I've also been involved with the lower left and the top, that's our governor. I've been involved with initiating some, Islamic focused, where we had where our holidays would be recognized and kids wouldn't be docked for being, out of school for all faiths, right? It was an interfaith effort. And in the middle, you can see the church, that's the Warm for Winter project, where we hung the hats and scarves on the pews. I would talk a little bit about homelessness and ask people for a couple of minutes of silence to just think about the individuals who would be wearing the hats and scarves. And the others are just some photos of some friends. The lower right, I'm the only woman in the photo. It's the East African community who invited me. I'm known in the leadership because I understand a lot of the local resources, so we'll be invited sometimes to gatherings. So I just look forward to your questions, and thank you very much for your time.
Wow. Janice, you raised the bar on everyone that has been working in PCORI within our community. That was an amazing story, not just the story, but the path of action that you have been on. And it's amazing what PCORI's methodologies and the frameworks can actually provide for the communities. And again, I share the passion with you, and I'm so excited and so delighted that you accepted our invite and you're a part of our journey. Thank you again. That's actually right. Nothing about us without us. That's what she says. Thank you, Janice. So can I have my slides? You can advance relatively fast because I don't want to take much of the time. I want to hear from other people. We have been talking about our projects for over 2 days. So this would be a quick recap in the next maybe perhaps 3 minutes or so. So PCORI, Janice has set up this stage. PCORI actually incepted back in 2010 with the Affordable Care Act. Just a reminder for those who are hearing about PCORI for the first time. So PCORI is a part of the Affordable Care Act. It got established back in 2010. By 2011, 2012, we actually see PCORI's materials online. In fact, Courtney will go over some of the details about exactly what that is in her presentation, which would start around 2:30, right after Dr. Padela's session, and Dr. Padela's session would start at 12:15. So we will go over that, but please stay tuned for all of that because I'm going over really fast on these things. So back in 2017, in the fall, Mosque-Community was first funded as a collaborative effort to bring out, to connect Muslim community with the PCOR engagements. And there were 4 participants in that. Dr. Padela led the initiative and invited 4 of us to actually join hands in engaging Muslim Americans for research on community health. So that was the project that happened back. We started in 2018 or December of 2017, I would say, and then gathered. So this is if you go on to the next slides on this. I'm going to be using my slide set, so please advance because I can't see on a small screen. I'm challenged there. Or visually challenged, sorry about that. So the next slide talks about the Muslim community activists from across the US meet at the Institute of Knowledge, California for shared learning on Muslim community health issues. So this particular project that Dr. Padela led, it brought about people from various walks of life and we had the 2-day Learning Institute in California, and we all went through the similar educational training about PCORI project management and the Muslim aspect of research and the Muslim dimension of research. So which you would hear all about from him. This is their team, the eMarch cohort. These were the participants that actually we all were in the same room, got the similar training, so that this journey of our shared experiences started back then in, I want to say, in 2018 fall. And since then, we all have been using and utilizing these methodologies and frameworks in many different ways. Today, we will also hear from Michael Van Kulen, Imam Sharif, and Samia Mushtaq, who have been actively using PCOR journey. Next slide will actually tell us about the first PCOR Mosque-PCOR conference, and that happened in October 2019, engaging Muslim Americans for research and community health. So I don't want to go into details about exactly what this project is because Dr. Padela's session really covers in depth. But in a nutshell, the cohort actually came together and they were looking at how to ameliorate health disparities in Muslim communities by using PCOR methods and being on the same page with respect to different frameworks. So there were 3 basic or 3 different priorities that came out ahead than others. And we said that those should be, Muslim communities should be focusing on those priorities. And so the conference produced quite a bit of materials, and we shared a lot of the different findings. One of the things that happened was this: we actually, the entire cohort came to terms with a similar, they came to terms with consolidating ideas and consolidating consolidating sort of the action plans or the thought process behind PCOR as to how we can adopt the methodology in Muslim community while keeping the Muslim dimension of it. So this particular toolkit talks a lot about how to do PCOR research in mosque communities and what is it that we should be aware of while when we delve into the different the details of the Muslim of the Muslim community or mosque communities. The next slide would actually then talks about the next step. We developed the PCOR toolkit back in the winter of 2020, and we said, you know, we need to disseminate this toolkit forward so that a lot of other Muslim community members who are doing research would be on the similar platform. And we need to now engage with PCORI, which has really the depth and the understanding to revamp the healthcare systems, not just for this country, but across the world. And there needs to be, the infrastructure needs to be developed. As Janice mentioned, she was talking about all of the different layers of information technology and research and patient-centeredness, and how the integration is happening. And, you know, that is the platform that PCORI provides us. We're connecting that platform to the grassroots communities in the Muslim communities, or the grassroots levels in the Muslim communities. So while we are connecting these two platforms, there has to be infrastructure that needs to be put in place for people to adopt this. And this particular toolkit actually provides and is that link that connects the two communities, or that connects the two entities, I want to say, for the lack of the better term. So this particular project, the Equipping Muslims with PCOR-based action-oriented research tools, which is what we are having the conference about today, is the second step after the development of Mosque-PCOR toolkit. We took the Mosque-PCOR toolkit, we developed a mechanism to perpetually adopting the toolkit to generate more and more PCOR project. And that method actually talks about the community health worker model. And we have gone over it in details about that yesterday. And if some of you who missed out on that session, please, it would be recorded and you can go back to it. Again, we were awarded, and we are very thankful to PCORI, who actually had faith in us that we would be able to do a second project and would advance the mission with patient-centeredness in Muslim communities. So, alhamdulillah, this project is coming to an end with this particular session. However, we are embarking on the journey for the next step. So this is really a commencement. And I welcome every one of you who are there and going to be with us in the next couple of sessions to really think through the next step as to how we can take the mission further from here. So in the next slide, it simply shows the EMPART cohort. These are all the people who were trained and worked as a team to bring about, they were trained as community health workers. We developed the program, we disseminated the PCOR, Mosque-PCOR information and patient-centered concept into the mosque communities. We're much farther away from the outcomes research concept, but we have at least introduced the patient-centered concept and the concept of patients with or connecting with lived experiences, as Janice has pointed out. So it is, and next slide, please. So what we see today is really history in the making. And with this particular conference that's coming to end, we are now thinking as to what the next steps are. In fact, the next project, a couple other folks who would be the PCOR researchers who would be providing the input, who would be presenting to us, would also share their PCOR journey as how they have taken lessons from the eMarch and moved forward. So this here's what you see if you see the Mosque-PCOR toolkit timeline slide, that we started out with four participants: Ummah Clinic, Whitestone, Worry-Free Community, and Islamic Initiative. We then moved forward. We had Pastors for PCOR, and thanks to Dr. Rebecca Johnson's guidance on that, we developed this community health worker model, and now we are ready to disseminate at a much larger level. Actually, we have already disseminated. We want to get a mechanism for the perpetual adoption of these PCOR tools and techniques into the Muslim communities, because I sincerely believe that it has the power to change the lives of each one of us. So today we are embarking on the third Mosque-PCOR conference, which would inshallah happen in 2023. And with this commencement, with this session finalizing, we would begin the journey towards the Mosque-PCOR third conference in 2023, inshallah. So with that, I want to give the microphone to the next presenter, Dr. Samia Mushtaq.
Assalamu alaikum, everybody. I'm Samia Mushtaq. We can move on to the next slide. And next one. Great. Introduction. So a little bit about me. So as Fatima mentioned, I was one of the participants in the eMarch cohort. I'm a board certified psychiatrist, and my journey in eMarch was around 2018, 2019. It was through my last year of residency in psychiatry and into my first year as a strategy consultant at Boston Consulting Group. So I took sort of a different career path after residency and was working in medicine part-time and the corporate world full-time. I'm now an assistant professor of psychiatry at UT Southwestern. And I have my own private practice for therapy. And if you could go back to the last slide, sorry, just finishing the last bullet. And then I founded my own consulting and educational practice, because that was something I was really interested in throughout residency, focusing on both community and corporate education around mental health and well-being. And so this was sort of the context in which my eMarch participation occurred. And so I'm laying that out there to kind of explain some of the takeaways and how I used what I learned in eMarch. Next slide, please. So my eMarch journey, as I mentioned, was towards the end of residency during my own development, kind of learning consulting skills and figuring out what I wanted to do in mental health. As Fatima mentioned, it involved a learning institute, bi-weekly webinars, and then a leadership conference. And you'll hear more about that, it sounds like, from Dr. Padala's talk, so I won't go into detail about that. But the core for me was around really developing concrete skills in how I thought about the research I had previously done, and then how I would approach it going forward, as well as the educational interventions I was doing, and really framing them in a way that was community-based and relevant to kind of the research. Next slide, please. So I really want to just spend a few minutes telling you about the real key takeaways that I got from all this time in eMarch, and they can't be distilled obviously in just 3 points, but consultants think in threes, and so I wanted to leave you with just like the key pearls that really stood out to me and framed my approach to education and research. So the first was, don't reverse engineer the problem based on a pre-existing solution. And this was something that I had kind of been doing, that I noticed early on, was I would think about what I wanted to do in mental health and then try to create a problem that would actually solve. And both consulting and eMarch helped me kind of structure problem solving in a way that's problem led, and identifying and defining what the issue is before proceeding into executing against it. The second thing was Dr. Padala's voice is permanently in my head asking this question: what is the Muslim dimension of the problem? I apply the same question now into the corporate setting when I do educational work with them. So if I'm with a specific business, I always try to understand like the organizational context of that specific business and why the topic that we're talking about is not being spoken about generally, but uniquely to them. The third point is managing a project takes a team. That's obvious. But in reality, it's very easy to feel like you're on an island, and all the work I've done since eMarch has really helped me contextualize that I am one person in a team that really needs the rest of the team and has to kind of be good about delegating and getting leverage from other people. Next slide, please. So real quickly, I'm just going to kind of give you a quick example of some of these points. So don't reverse engineer the problem. Figuring out how we know what we actually know is so critical. So I work in mental health, and one of the things I always hear from the Muslim community is mental health is stigmatized among Muslims. So that's the claim that we frequently make. But the question that eMarch made me answer is, do we actually know that, and how do we know that? What is the data that we're using to support that claim that it's stigmatized among Muslims? Are we using focus groups, surveys, utilization rates of care to really understand this? Next slide, please. So when we break it down a little bit, on the left-hand side, there's the graph from a previous study that I had read by Dr. Awad, in which she looked at who people would seek for mental health treatment. I had done a similar study on a smaller scale, looking at, in my own Nashville community, who people would reach out to for mental health problems. And what I saw was that if you see the second pair of columns, that's people seeking therapists. And it's actually higher than people seeking imams. So that actually caught me by surprise, because we're making this claim that Muslims won't seek mental health care. But I actually saw, at least in one small study, that they were willing to. But they actually were less willing to speak with physicians. So I thought this was interesting. And that was kind of the initial framing of the problem. Next slide, please. Now, what I found from the results of that study was that regardless of how people constructed whether depression and anxiety, mental health conditions, are framed as physical or spiritual problems, regardless of their views about diagnoses, what I was seeing was that it wasn't so much therapy that was as much of the issue as it was medication. And there was definitely a threshold of stigma around medication that was lower than that of therapy. So I thought that was super interesting. Next slide, please. So now whenever I talk with folks about mental health being stigmatized, especially people who are not prescribers in mental health, that's something I try to make a distinction about. Are we talking about certain illnesses that are stigmatized? Are we talking about certain treatments that are stigmatized? And what I'm starting to see is that medication is certainly treated a little bit differently than therapy in terms of how open people are to it, which changes how you think about solutions around stigma and access to care. Now, the next point was, what is the Muslim dimension? Should I move to the third point? Okay, so I will just go through the second point really quickly. So what is the Muslim dimension? So when I was doing an educational intervention for a mosque, once COVID started, the point that I was thinking about is, why is this happening in a mosque? What makes it relevant to the Muslim community? As you all remember, COVID was happening at the onset of Ramadan. And so there was obviously a very unique aspect around social isolation and lack of community that was occurring in that context of a time where Muslims are obviously very engaged in community, which completely changed how people thought about their mood and the anxiety that it produced, because this social outlet that people had, that Muslims had, was stripped away. So this came up in the COVID talk that I did at the mosque. Was that was one piece of it. Another piece that was uniquely Muslim around COVID was a lot of male physicians were having to shave their beards to keep their N95s secure. So that was another thing to be thinking about, was at the intersection of identity and practice, what was different and unique for Muslim people. Okay, I'll move us along now to the third point. So managing a project takes a team. So again, as I mentioned, we're not on an island, need admin support, need design support, need to have a clear implementation strategy around what we're doing. Retrospective review and data analysis is another piece. And what I've just learned is that need to leverage skills from different people in different areas, and having a team going in and figuring out who's doing what is so critical to the success of a project. And next slide, please. So just a visual about that. That was a group that we did for the Christchurch shooting. We had a process group at our university. And again, that 1 hour probably required several hours of back-end support. So just keeping that in mind. I know we have to move things along. So that was the key points I wanted you all to know. And thank you for allowing me to share them with you.
Wow, I am intimidated now. And so what an amazing presentation so far today. Thank you so much. And I'm also now, the fact that I'm being included in this, my ego is going to be such a problem for the rest of my family for I don't even know how long. So thank you for the invite to be a part of this. Imam Sharif Muhammad, who you'll see in this picture with me, he had hoped to be here today, and it turns out that he wasn't able to negotiate his time. And so you've got me. A little bit about me. I have been partners with Imam Sharif and working in community for about 20 years. We're co-founders of what you see as Open Path Resources, which is a nonprofit that is sister with another nonprofit called the Islamic Civic Society of America. And ICSA, as we call it, is home to the Dar al-Hijra Mosque. The Dar al-Hijra Mosque is the first mosque opened in Minnesota that was led by the Somali community. And the Somali community arrived in large numbers in the early 1990s, following the falling of the central government and the immigration and refugee status coming into the United States. So since that time, we have been in close relationship and working together, and it has been transformative for my life, and I'm very proud to be a part of it. And I deeply regret that you don't get the chance to be with Imam Sharif on this presentation. I'll do my best. We can go to the next slide. So from the outset in our work, we have been looking at how do we think systemically around our work. And one of the key pieces is we sought to have faith centers, mosques, to play a central role in connecting various aspects of community. And for the purposes of this conversation, equity and positive health outcomes. We also work in education and other government agency entities, etc. But a great portion, and since COVID, of course, dominating our work, is how do we build bridges and connections between various institutions to produce better health outcomes for all of our community. What we understood was we had to make certain that we understood community interest and built in community voice in all of our work. I'll give you an example. When we first work, we were offered the opportunity to run a center, an autism center, a center addressing autism in the community. We know that through some research from the CDC that the Somali community in Minnesota has a much higher rate of autism diagnosis than any other population in the United States. We still to this day don't know why. The point is we were given an opportunity to explore, would you like to run an autism center? We spent 6 months thinking, is that a good idea that we do that? There's certainly a need. But from that work, we discovered that there was a tremendous gap between mainstream systems, healthcare systems, institutions that were internationally known for their work with autism, but they had very poor outcomes for East African or for non-dominant culture communities. We additionally looked at some of the community-based institutions that were addressing autism, and we did not discover any better outcomes in that model. So what we set about to do was to think about how could we start to close the gap and build bridges between institutions and community to produce better outcomes. Let's go to the next slide, please. So other than providing you with a fancy slide here that you can't read too well, perhaps, the point being, we invested heavily in community conversations, community engagement. We did 500 one-on-one interviews across Minnesota, sort of exploring where should we go with this work? What does this mean? And how do we make certain that we are always driven by community voice defining the purpose of the work and the purpose and selection of outcomes that we seek. So this is a rather complicated slide that we try to demonstrate how we set about engaging, re-engaging, circling back to make certain that we are not just checking in and now we've got an assignment from the community, but we're developing a process of continuous engagement and relationship between ourselves and that community interest, but also then we're able to produce an outcome that is, so if we reach to a healthcare system, a hospital, etc., our goal isn't that they know us, that we're the voice of, we think that's something that's that dominates our environment, where a community is lifted up and suddenly they become the face of, and then they control the narrative. And so in our effort to constantly be looping back, reaching back, and organizing in community, we hope that the result of this and all of our work is that it's actually a relationship between broad community and institutions like healthcare. Moving on. So as we were approaching further clarity, we were given an opportunity to join the eMarch program. And that was a brilliant opportunity for Imam Sharif and myself. One, to participate and work alongside and discuss these issues from a national perspective, but with brilliant leadership and a cohort of really wonderful people. So we were given an opportunity to explore some of the spaces we were in. At that particular moment, we were heavily invested in, and still are, in a Muslim chaplaincy program. Imam Sharif became Minnesota's first Muslim chaplain in the history of our state. In that same time, through our research, we were able to determine that there are 12 Muslim chaplains in North America as a total, certified Muslim chaplains working as an interfaith hospital chaplain. And so clearly, there was a great need to increase that number. And we set about trying to discover what were the barriers that were holding folks back. Why was the number so low? From that work, and with the support of eMarch, we then identified 23 individuals that we walked through what we, CPE, which is clinical pastoral education, is the process within a hospital system, how somebody is trained to become a chaplain. We had identified several individuals who'd gone or tried to go through that clinical pastoral education and discovered that it just wasn't a fit. They felt so uncomfortable. It felt so Christian in its orientation. And so we created a pre-CPE program that lasted for 1 year, where we walked through and helped individuals prepare for that experience, and then build a community so that when somebody entered, they weren't alone. They didn't have to deal with complex theological issues on their own. They had others who had a similar understanding and a similar interest to sort of have conversations, explore, test ideas. And I think that's been very important. To this point, we have now in the Twin Cities area have 5 Muslim faith leaders, men and women, who have moved and have been hired into the hospital system. So within that initiated 2 years ago, within these 2 years, we've increased the number from 12 to 17, as we understand it, in North America. That's been a positive piece. At the same time, COVID arrives. At the same time, in the Twin Cities, we have the murder of George Floyd. And it cannot be overstated how significant that event of George Floyd was. If you've seen it at an international level, you've seen it around the country, but in the Twin Cities, it is as powerful an impact upon our health system, upon our society, as COVID has been. I think that's fair to say. And so both of these events had a really big impact on how healthcare felt in relationship, how it served, how it understood its goals. During COVID, at the outset of COVID, we were also then able to attain a PCORI grant to begin to explore how does healthcare, how does society better engage and lift up the voice of the broader community. During COVID, it was generally understood, oh, there's just no way to do research. We can't reach people. We have to isolate, all these things. So what we did was we designed a model to sort of to explore how do we effectively engage and gather community voice as broadly as possible, even during the COVID time. So with the project aims of this initiative, we wanted to engage community members for input and asking them across this community, what sort of research would they like to see regarding healthcare? What is it from their perspective is needing to be looked at closer and be given more attention? We then aim to disseminate that feedback on this various novel methods of patient engagement and stakeholders and partner organizations. And then finally, we wanted to use case studies to evaluate at least 3 key methods of engagement techniques that were being used across Minnesota. Next. Please. So from the outset, we created a statewide community advisory group. We had 10 individuals representing probably 8 communities around Minnesota, 8 city, towns, etc., all representing Muslim community. The vast majority were representing the East African immigrant population. I should briefly clarify that. Minnesota has around 150,000 Muslim community members. 2/3 of that are East African immigrants who've arrived in the last 30 years. They've had a very large impact on the number, but also the Minnesota sense of what it means to be Muslim. Mainstream white Christian aging population of Minnesota, when they think Muslim in general, they think Somali. We had President Trump come to Minnesota during that time and give frightening speeches in Minnesota about fears around the Somali community, etc. So that orientation dominates the sense of what Minnesota perceives as Muslim. And problematic as that is, any kind of work we do, if anybody says this is what Muslims think, you're lost from the very beginning because you're overgeneralizing. There is no singular, I can't think of a singular concept in general mainstream life that says all Muslims think a certain way on almost anything, let alone all East Africans or all refugees think a certain way. So I want to narrow down the understanding of our work to say we really did then focus on the Somali experience, and we found the community advisory group to represent Somali experience. And we are very cautious when we say this is what Muslims experience or think. But we shared this statewide approach, developed these survey questions, and we created ambassadors. We created 45 ambassadors from the Somali community. And what they did was they identified 15 to 20 individuals that they helped engage in participating in this survey. The survey took place between December 2020 and January 2021. 941 respondents to that survey in that 1 month or month and a half time. And to our understanding, this is the largest survey to take place within the Somali community of Minnesota that's ever been done. And it was done during COVID at a time that it was assumed you couldn't possibly gather. And the other reason I think we really value the outcome of this is because it demonstrates that it's possible for healthcare to open the doors to community voice. It is possible to hear about the Somali experience or Muslim opinion that is beyond just a couple leaders, beyond a specific mosque, beyond a specific imam or healthcare provider, etc. So that was one of the important outcomes of this effort. Next slide, please. Some of the outcomes of this work, we discovered that 84% of the respondents, this was the first time anyone had ever asked them about healthcare, let alone research in healthcare. So that I thought that was a very important piece to understand, that for the most part, people aren't asked, I think. They're represented, certainly, but seldom talked to. 76% of the respondents said they were extremely interested in participating in future studies. So now we do have a network across Minnesota that for future efforts, future conversations, we're able to engage this large population and further explore concepts. Factors that would encourage research participation: trusted connections. Being paid, that's increasingly becoming a sensitive issue. Should participants be paid? In this scenario, our ambassadors were paid. The individuals taking the survey were not. They wanted to express that they wanted to be certain it was a topic they cared about. They wanted help in understanding research. If they were going to be surveyed, they wanted a little more information about what that means and what does research imply. And but a smaller percentage felt like they were already ready and prepared. So when we think about the Somali community, one thing to know also is they arrived in rapid fashion, and a full expanse of the community everywhere. Anyone from the former prime minister, heads of universities arrived as refugee, and also nomadic individuals whose family had never been to school. So a full swath, a full range of community arrived at this time, and each of them have voice and right to speak to their health, obviously. And as you might guess, some are less likely to be given opportunities. And we were just proud to be able to reach out, and what I think we were successful in reaching that full diversity of community. Next slide, please. So for next steps, by gathering, if you could go back one, or the conclusion. I'm sorry, that's right, conclusions of the core study. So the Somali community in Minnesota is very engaged, eager to participate, as I mentioned. One of the fundamental pieces that we want to do in our work, and that we think this survey work demonstrated, is that it's possible to sustain dialogue. It's possible to build partnerships with more than just the face of. And fundamentally, from that work, we've discovered we want to build relationship. So as we've been working on the Muslim chaplaincy program, what's key for us in that is that we're bringing faith into the healthcare system. It isn't just the healthcare system talks to community. We want relationship in the hospital system, in the healthcare system, as well as in the community. And we're trying to create more of a systemic orientation to how we reach positive health outcomes. So right now, as we have Muslim chaplains hired and playing roles, critical roles in hospital systems, we also are increasing the number of community chaplains. And what that means is that these are individuals who are more adept at understanding and being engaged with healthcare systems, but playing a role in the community. I'll give you an example. In the mental health system, we have somebody, a Muslim community member who is receiving mental health care and then is going through discharge, and then the return rate is extremely high. They're discharged, they're given direction, but the trust, the relationship, the engagement is so weak that they frequently will then return, producing the same problems over and over again. Having a community chaplain allows us, one, to have relationship inside the hospital in the mental health treatment experience, a part of the discharge process, and then part of the community support system. By being a part of that full the full narrative of care, we're not only able to sustain across that time, but create a cultural component, a faith component that more in a healthy way engages family, in a healthy way engages the mosque and the faith community to support issues. And in that way, We, one, support that individual needing care, but we also advance the community's understanding because they're more richly involved. So this is a bit of what we talk about in partnership and relationship. I think we can go on to the next slide. So next steps, we're going to continue to work with the diversity, equity, inclusion aspects of our healthcare systems. As I mentioned, the murder of George Floyd has so dramatically affected how healthcare systems perceive their responsibility in community and their desire. What we're cautious is this a reactionary moment? Can we build systems that will sustain and be meaningful and profound for community and produce a better justice as well as health outcomes? That's to be seen. The faith community is developing its imagination for its role, and that's a complex space. So how do we build a community that is capable of being in right relationship and in partnership with healthcare systems for family, individual, community health? We think that work requires an organizing agency, an entity that does travel and represent back and forth in these systems. So OPR right now is trying to play that role, but we're not trying to dominate. We're not trying to say we are the force, the voice of community. We're just trying to help organize, to be honest. We seek a holistic vision to address these inequalities, systemic in our orientation, trying to understand each aspect of that system and their self-interests and their capacity to play a role. And then finally, one of the goals we have is then a replication model, because we don't want a system that says OPR is the organizer, and if you want to do this work, come to OPR. We want to make sure that across Minnesota, each region has its own local and regional connections and relationship, and we're in the process of trying to develop that. That was a lot. I hope I didn't go too long. Thank you for the time.
Assalamu alaikum, everyone. My name is Mehreen. I was one of the community health workers, part of the MPART project. Move on to the next slide. All right. So this is just some of my reflections from the project. You can move on to the next slide. We underwent 4 weeks of training with several hours over the course of a month. We underwent Mosque-PCOR community health worker training, which was based on the eMarch project, which aimed to highlight healthcare disparities among Muslim communities and created a resource to kind of help us as community health workers better understand the needs and limitations of Muslim communities and kind of bridge that gap between what we knew were limitations of the Muslim communities and kind of go out into the field and kind of see for ourselves. And we had an amazing opportunity to learn from trailblazers in PCOR, Dr. Rebecca Johnson, Dr. Asim Padella, and many other speakers that came and kind of talked about their experiences with us, which was great to kind of see that perspective. We did have to kind of pivot our approach when it came to community engagement and outreach because of the COVID situation in the Chicago area. So we had about 250 hours of virtual outreach over the course of 5 months. Myself and the rest of our cohort, we kind of split up different shifts and manned the phone lines over these 5 months and kind of talked to patients from our respective mosque communities about a lot of the needs they had, including like healthcare access, insurance issues, vaccination support. So a lot of these people, I think one of the most popular reasons why people called was to kind of get the vaccine. A lot of them were elderly individuals who were unsure on how to sign up for the vaccine, and then social support, whether it was, shelter or food pantry access. So we kind of answered questions about all these different things and kind of helped direct people to the correct resources over these 5 months. And so we took into account these PCOR principles throughout the time that we were engaging with the community, both in person and over the phone. And these principles included reciprocal relationships, co-learning, partnership, and then transparency, honesty, and trust. You can move on to the next slide, please. So for VertReach, we kind of took a different approach to kind of get the word out that we are available as community health workers to, address people's needs. So we put up these posters. We disseminated text messages with the phone number for our VertReach phone number. And we were able to communicate with the individuals from each of our respective mosque communities about their unmet healthcare needs. So like I talked about, from healthcare access to vaccinations to insurance needs, as well as social support. And then we were able to educate people. A lot of people had different questions about like the safety and efficacy of vaccines and things like that. And so it was really great to be able to kind of answer those questions. And I think we were able to, a lot of us spoke different languages in like the patient's own native tongue. So like we had community health workers that spoke Arabic. We had community health workers who spoke Urdu. And so we were able to kind of reach out to these communities and populations in the way that they felt most comfortable. And I think that helped kind of establish that trust, like we were talking about the PCOR principles. And I think that was a really great opportunity. Next slide, please. So these were just some of the community outreach events. Once the COVID vaccine came out and we were able to kind of safely go out into the community, we did have a little bit more of that ability to kind of go out and mingle safely with people. And so on the left is like one of the blood drives that we we partnered with Mass PACE, and we were able to go out in the community and kind of help spread the word about the vaccination drives that we had. I'll get into that in the next couple slides, as well as our phone line and then some of the other community events that we hosted. And then we also got to go out into the community and like put up flyers, speak with like store owners, other community organizations. And it was a really great way to kind of integrate ourselves into the community. And it didn't feel as distanced and like, I guess, like impersonal as it did on the phone. So we kind of got to have some of that in-person aspect, which was great. You can move on to the next slide, please. So one of the community outreach events we had was Ask a Doc. And it was basically, there were several events where doctors would speak to patients about the COVID vaccine and questions about COVID in their native language, which was kind of like one of those things that came up repeatedly. Like people just felt more comfortable speaking to someone who understood their like native language and just like cultural practices that are kind of different, even among different Muslim communities within Chicago. So we had doctors speak in Yoruba, Arabic, and Urdu, and it was a really great opportunity to kind of see that, I guess, community engagement. Even though it was virtual, it still felt a little bit more personal because people were able to directly speak with these doctors, which is something that they wouldn't necessarily get to do otherwise. So we had Ask a Doc, and then, like I said, we had other local events. And then I kind of talked about this, but we went to different businesses and spread the word of our mission. And then we had partnerships. We made partnerships with other community organizations and increased our reach and impact among Muslim populations in the area. Next slide. All right. So one of the other things that we helped participate in, and we partnered with Compassionate Care Pharmacy for this, was the opportunity for community members to get vaccinated at their own masjids. So I personally worked with Muslim Society in Glendale Heights, and so community members were able to get vaccinated at their mosque. I think it was great because it was culturally sensitive care. Men and women were separated. And then we also got the chance to kind of talk to these community members and patients who came in to get the vaccine and kind of, dispel a lot of these rumors around the COVID vaccine. And people had lots of questions that, maybe they didn't feel comfortable like asking over the phone, and they knew that we were there and kind of, they felt comfortable asking those questions to us in person, which I think was great, just to be able to integrate within the community and kind of understand like what people's main concerns were, and kind of I think it was good to establish that trust, and people were able to go back. So we had a couple vaccine clinics, but I think like the first time we went in, there were people who were kind of unsure about getting the vaccine, but then the next time we came back like a couple weeks later, they're like, okay, can I get my family members to come in and get the vaccine too? So I think it was really great because we kind of sat down and we talked about these concerns, and then it kind of helped build that trust. And I think it was a really great opportunity. So next slide. And then the last thing that we did towards the end of the project was we had our town halls with each of our respective mosque communities, which was a way to kind of gather input. So from our experiences, and then relay our findings back to our mosque communities. We had open communication between our team and the mosque board members. The mosque that we partnered with, a lot of them had weekly newsletters that they would update with our community events. And then the community members would kind of come to these events as a result of, the newsletters being sent out. We talked to our mosque community, like board members, about the successes and challenges due to COVID. I think for my particular mosque community, one of the greatest successes was the vaccine clinic. But then another kind of con to this whole COVID, the pandemic, was the lack of in-person events. So while we did have the ability to go in and kind of engage the community in terms of like vaccination events and things like that, the community really suffered because they didn't have that like community outreach, and a lot of these things like the weekend Islamic school, the HIFS programs, the after school programs kind of had to close down as a result of COVID. And that was something that happened across the board for all of these mosque communities, it wasn't just mine in particular. Next slide. So overall, I think this was a wonderful opportunity to learn how to better serve my community. It was a great way to improve my knowledge and understand the barriers when it comes to equity of healthcare. Language and literacy is one of the key points that came into play in all of this. I think people feel so much more comfortable when they have someone who understands their cultural, their religious practices, and is able to break things down in a way that they understand. And it just helps establish that trust so much more. And then it kind of helped me understand like what resources people seek out when it comes to improving healthcare. So like, free healthcare clinics. We connected people to, different types of businesses, services that they seeked out. And then also brought to light a lot of these logistical issues that people face when trying to access adequate healthcare. So like transportation, availability when it comes to vaccines, the language barrier, wait times. These are all things that play a huge role in Muslim communities and kind of having Muslims access quality healthcare. And I do think that this project will definitely, inshallah, pave the way for further research and interventions within Muslim communities, not just in Chicago, but inshallah throughout all of America. Thank you.
All right, Assalamualaikum. So my name is Joy Rasul. I am a foreign trained physician from Pakistan, and I wanted to talk about a little bit of specifically creating the partnerships during the pandemic, specifically for us as community health workers with the second PCOR, Mosque-PCOR project, EM part. So just for some background, I do have some experience in creating a patient care association. And one of the things that I really loved or that I notice and that I find important is communication, because different cultures and different people, and especially with the immigrant community, you have a lot of communication barriers. And so then I first of all want to thank everyone else from before for everything that they've done. It's amazing. And I think it's just really important. So going forward from everything that everyone has learned and has done and what we have been through, let me just like kind of summarize some of my reflections. So if you want to do the next thing. So I have these 3 words on the slide because I think these are the 3 main concepts of what we had to work with during specifically the pandemic. So outreach, collaboration, action. So there's all these things that we do for everything that's in the Mosque-PCOR toolkit, and like creating like with the PCORI principles, co-learning, making relationships, reciprocal relationships, establishing trust. So because, as Mehreen was saying, we had to kind of switch gears from a in-person situation. We had to do virtual reach, which was a little difficult. It required us to stretch a little bit more some of our skills, create new skills of like trying to establish that trust over the phone, over online activities, over email. And we didn't get that much opportunity to be in person, which is, I think, what most people are trained for. Another thing is that we had an opportunity to have like unified action and collaboration because of the pandemic, which I think was a strength of this year as well, because it allowed us to focus on one main thing that every single person was concerned about. And we got to see a depth of like different experiences and different ways that different communities were processing all of these things. And so it can help us be better communicators and help connect more with our communities, hopefully in the future. Next slide. So specifically, what I wanted to talk about is that physical outreach versus virtual reach situation. So there's 5 main types of communication that we could say that exist in the world. So you have verbal, which was very easily covered over the phone, which we noticed during our calls during the virtual reach, that the ability to speak well and to speak in their language got people to open up and create that trust so much more. And there was like, so I can speak both English and Urdu. So if I started out with English, without an accent, I would hear so much hesitancy. But then as soon as you switch over, it's like a flower blooming. Everyone's like they open up, they want to talk about everything, all these things that they're afraid of talking about. They will start talking about, because now they know that maybe you can understand where they're coming from, whereas they might have some, and this is my like extrapolation from what I heard in other people's voices, but it felt like they would feel like maybe someone can understand where I'm coming from, whereas if they're speaking in a different language that they're not as good at, they might not be able to get their point across or reach that level of understanding. So that was covered. That was okay in our project. The second one is the one where we really, really struggled, because a lot of communication is nonverbal. So unless you were on a video call or in person with someone, it is very, very difficult to catch up on all of these things. And those things are also all these things that create trust between people, which I felt like I saw when we were trying to connect with the mosque communities themselves, like as a community health worker with the mosque boards and the people who are in charge, and trying to get projects going or trying to get outreach going with people. Obviously, everyone was very, very accommodating and very like open. I'm not saying there's any problems there, but there is a little bit, I think, of difficulty creating some of that trust. And that's what required us to stretch a little bit more, because I think I noticed that I kind of was relying a lot on nonverbal communication, of like being accepted immediately because I wear the scarf, or because like, you know, being like at a peaceful state of sitting, where you can also make that message get across with your verbal and how you speak, but it's still, there's a lot of stuff missing there. Another thing, so the third type of communication, written communication. So we did try really hard with that. There were newsletters sent out. We tried to create a blog or a website where we could post blog posts. The only problem with that was getting people involved enough to log into these areas and kind of go look at them, which I think maybe we need a little bit of work on. We were trying, you know, different techniques and trying to make that happen. Second is, the fourth type of communication is listening, which was another thing that we got to do in VertReach really well. I think perhaps, I don't know if we would have had as good of an opportunity to do the listening portion, because it was one-on-one. People could call on their own time. They were able to talk about the things they were afraid of, or ask advice, or get directed in a certain direction for something. So that one, I think we had a couple strengths this year with the project. And then the fifth type of communication is visual, which, you know, like in presentations, in like some of these posters that we had some visual communication, but some of it was also missing because of that nonverbal communication, or that in-person aspect of everything. And we didn't have any video calling for the VertReach, so that was also a little bit something that was missing from our project this year. Next slide. All right. So just wanted to go over the communication process and some of the other things that we noticed because of all these factors. So you have a source, you have the message, you have the channel in which it's going through to the person receiving it, which is the fourth one. Then you have feedback from the receiver, and then the environment and the context and the interference are three things that are also part of the communication process. So specifically in this year, we had a lot of stuff online. So some of the environmental and the interference from that aspect was off, but otherwise, I think we were able to do a lot of things. Some of the things that we noticed were trying to get different age groups and different cultural groups to get involved with our online and with our our efforts this year. And I think that's something that, even if we're not on VertReach as community health workers, is something we're going to have to work on all of our collaboration with the Mosque-Communities, which is figuring out different age groups. Ages are cultural too, so different age cultural connections. I know some of the stuff that we discussed that we were like, maybe we can try to do is get younger people involved with the older people who are more experienced in like the masjid boards, to kind of have a more comprehensive connection with different families and different communities and the community as a whole. So that was one reflection that I know we talked about a lot, and there's so many things to talk about, but I know we're running out of time and I still want time for questions. So we'll just go ahead and go to the next slide. All right, so this is the VertReach model, just a nice picture representation. We had live online chat. We had a form where people could leave their information, get called back or contacted back, and we had the phone line, of course. We had community resources as a online resource directory that could be accessed and added to. And then we had Ask a Doc for, as Mehreen was saying, and other like vaccine clinics and everything that we had. But that wasn't part of the virtual outreach, but the Ask a Doc and all these other things were. Okay, next slide. Some of the data, just wanted to present that to you, just to give you like an image of how what we discovered created more traffic. So a lot of these invites or the emails for an event garnered a little bit more attention on our website. So we noticed that if we do constant action, constant like programming, it's a better way to get everyone involved because it's something interesting, especially in the context of the pandemic where everyone is quarantined and can't go out much and can't connect in other ways to the community. It helped out a lot. So you can see the little spikes for each one of the emails and each one of the events that we had right there. Okay, next slide. All right. So for the phone channel data, a lot of the phone stuff we noticed was surrounding around the type of information, the type of needs that the community had. So in November, December, we had a lot of calls because of open enrollment. I think that's a time of confusion for a lot of people, and having the opportunity to talk to someone in your own language helps out a lot. Ramadan, also, it's a time of connection with other Muslims in the community. And this year, because of the quarantine and all those issues, there's another spike not spike, but there was a good amount of connection on the phone channel due to that too. And then 3, people are getting to know us better. And then when we put the outreach posters, because it's kind of trending downwards, when we put the outreach posters out into the community, it went back up again. And when, if you ask some of the patients who are calling in or the people who are calling in, they would be like, oh, I saw your poster, or my friend saw your poster, and I was just wondering, could you help me with X, Y, and Z thing? But yeah, basically those are what was happening kind of with our engagement with the Vert Reach on the phone calls. All right, next slide. All right, just for conclusion and reflections, again, I think this year there's a lot of things we couldn't do, but a lot of things that we were able to do that we might not have been able to do if it were not for the pandemic. For instance, like vaccination drives, I think was an excellent start because it was a need that everyone needed, and it kind of was a great introduction for these programs, because establishing that trust and like having a collaboration between the masjids and between like our organization and connecting people and informing them and spreading the word, all this. The free clinic as well is like an excellent resource that was pushed forward, I'm sure, because of all the events of the pandemic. And then Ask a Doc, I think personally was one of the things that I thought was really amazing that I could not have imagined before for our communities. And I learned a lot during it. And I am really excited to apply all these new things that I've learned with PCOR. And I hope that our communities will do, and we already see this with our predecessors, but they're doing excellent work incorporating all of these things and moving forward and helping us all move forward in these efforts. And that's it for me. Thank you.
Well, thank you, everyone. This was refreshing, energizing, and you have already set the fuels to so many vehicles, I think, to kind of initiate and continue whatever they have been doing so far. I really appreciate sharing the experiences and the trajectory. And we have a couple questions for you guys. I believe Nabil asked if with or without the mosque toolkit and questioning the incentives or exploring the incentives of Muslim communities to participate in research, how do you actually raise awareness amongst lay Muslim community members of the importance of them participating and engaging in research projects for patient-centeredness?
Maybe I could offer something briefly. I think it's an expanse of the imagination of one's role within the healthcare experience. So to just say participate in research around healthcare, it can feel very abstract if we haven't already explored from an Islamic frame, we as Muslims, what is our role and what are our beliefs around prevention and care for our own health? And when we start to explore that and then look into research, I think we have more luck.
May I just remind a quick thing? So I know I wanted to leave a room for Q&A, and we wanted, this is amazing presentation, and each one requires at least 20 minutes Q&A. However, we would be running into our second session. We will start streaming it at 12:15. So at least people who are joining that they're still able to join it, but we would have a message that we would engage at 12:20 or between 12:20 and 12:25, so that this session folks have a little time to stretch out and you have enough time to join the next session. But however, we can use this time till 12:15 or 12:20 to engage in Q&A, please.
I might add to some comments on that. Really, before I became involved with PCOR, I didn't know much about research, and actually I was pretty cynical on it because I just thought so much work is done and how much do we really know? And I had never applied to be like in a clinical trial or anything. I've never, gone down that road. But now that I've been involved with PCORI, I mean, really anything is possible. And what we've developed, the one that I mentioned that I kind of initiated with the University of Michigan Public Health Institute is it's on disparities. And so we'll see where it goes, but using a specific toolkit, and it's only PCORI ambassadors that are all coming together from different walks of life, right, and bringing their perspectives. So also right now they're looking at, deeply into individuals with developmentally, challenged situations. So also as well as, mental health. So PCORI is focusing in areas they haven't focused on before, and which is very important. And I think overall that people would be greatly appreciative if we had more of like what Michael was talking about autism, more knowledge. I know we had some research done here locally as well. But these are areas that there is a lot of stress and stigma around, but it appears like Dr. Mushtaq had shared that it was interesting that they were looking at, therapists, right, rather than imams. So I think this would be an interesting area. And putting in the proposal, as you all know, is a lot of work, but it really might be beneficial, nationwide. Thank you.
Let me add to the same question, unless we have another question. So here is the biggest disconnect or gap that we see in the mosque community. Once you hop onto the PCORI platform, the ride is smooth and it's a zip. It's literally like a bullet train. But that jumping onto that train is where people are challenged. They are not going to jump onto that train till it makes sense to them why they are jumping on. So it is key to understand why would you do something. And in order for the PCORI ambassadors who are actually on this side of the fence trying to engage the other person, I personally think that these 5 principles work like magic. And it is involving these 5 principles into our actions and weaving them into our communications and the verbiage is how I was able to cross that barrier. And especially the reciprocal relationships. We think that, oh yeah, we have this or they have this, but reciprocal relationships in what do they want ties very deeply with their intent as well as their priorities. And intent and priorities may not be the same thing. People think that, oh, this is my intent, but they have a different priority. So helping them recognize that barrier within themselves is really where the disconnect and the gap is. So I think this engagement work is extremely important right now where the healthcare, with this particular healthcare status, I see the engagement work is much more important than the actual comparative effectiveness research work. I'm not trying to overshadow, but I think unless we engage these communities, we're not going to have enough people who would say that, yes, this is really what matters to me. And I would like this particular treatment versus this treatment. So exploring all of those options are really possible with these principles.
Well, thank you, everyone. I believe, hopefully, Nabil, that you have gotten your answer. It does seem like the PCORI toolkit has strong advocates behind, as we all know. And I think Dr. Van Koolen has given a great suggestion to use your imagination, your platform, your role, and most importantly, bust the myth that research is actually a complicated, sophisticated process or using big words, and make sure that the terminology, taxonomy that you use with your community is one that they identify with, that they can engage with, and then identify their stake because it's a heterogeneous community that you're dealing with. By that, I would like to conclude this wonderful panel. Definitely, we don't want to close that. Hopefully, the conversation would continue to be ongoing. Thank you all for sharing your experiences and for bringing this wealth to this platform. And thanks a lot to you, Fatima, for making this happen, and for the instigator in the background, Dr. Padilla. You guys have a great day, and I look forward to the next sessions, inshallah.
And I just want to remind that everybody, please join